Assalamu alaikum wa barakatuh. It's my pleasure to be with you today. I would like to thank the organizing committee for the kind invitation, and I wish you all a fruitful conference. I'm going to talk about use of technology and diabetes. I have no disclosure. Just I want to share with you first two cases, real case from my clinic. The first one is Mr. Rashid, one with long-standing type 1 diabetes, not controlled for many years, ended with end-stage disease, and he had transplant, and is using now the advanced hybrid closed loop system 780G with A1C 6.5. Another one, Mr. Ahmed, who took care of himself initially, and he used the insulin pump for a long time, 13 years of his diabetes, and he continued to have good control with A1C 6.6 on another automated insulin delivery system, the Minimed 670G. This is the agenda of my talk. First of all, please, if you have this TV at your home still, you have this one, you can raise your hand. Anyone has this TV in his home? No one, I think. Still good. Okay. So think technology about diabetes this way. Technology is not an add-on. Technology is a standard of care. It's becoming to be the standard of care, not an add-on. I will not have these two TVs at my home. I will replace with the new one. This is technology in diabetes. It's becoming like that. This is the yellow strip, the time of patient with diabetes will see any one of us in the clinic, maximum 2 hours per year. So it is a mainly self-management disease, and we need to empower our patient with technology to manage his disease. Think about technology like your mobile phones. It is Moore's law about technology. It shapes like doubled every 2 years, and I think this is old law. It is now more advanced, and this is a technology since invention of insulin until now is the advanced hybrid closed loop systems. Now, what are types of technology? Just bear with me, this is the whole map we have. We have technology on the patient side and technology on the physician side. Patient side, we have the CGM, continuous glucose monitoring, insulin delivery with using smart pens, insulin pump, the integration between pump and CGM at different levels of technology until reaching the bionic pancreas, completely closed loop, artificial pancreas with insulin only or with combination with other hormones, and we have mobile applications. On physician side or healthcare system, we have telemedicine, remote monitoring, artificial intelligence for decision making. First, what is CGM? CGM is a device to continuously monitor the glucose level in the interstitial fluid. As you can see, sugar or glucose will move from blood to interstitial fluid, will be measured by sensor, and then a transmitter to move it to a receiver. The receiver can be a dedicated device, can be your mobile phone, can be your smartwatch. What are types of CGM? We have personal CGM and professional or blinded. The personal CGM is the device owned by the patient, continuously monitoring the sugar. It can be real time. Patient can see his sugar on his device continuously, or intermittent scanning like the flash glucose monitoring freestyle Libra by scanning. And the blinded CGM, it is blinded to the patient. It is owned by the hospital. Patient will come back to review the data retrospectively with the doctor in the clinic. Data we can get it with CGM, too much data, time and range, hypoglycemia frequency, hyperglycemia frequency, duration, severity, and variability in glycemic control. What are common real CGM we have? We have the Dexcom system, we have Medtronic system, we have Eversense, this implantable CGM under the skin with different durations, 10 days, 7 days, or 6 months, for implantable one. This implantable one through minor procedure in the clinic. And it can give different alarms at rising sugars or decreasing sugars, alarming the patient before hyper and hypoglycemias. All these systems are improving to reach two things: better control, better accuracy, and more user-friendly. Thinking technology, give me or give patients with diabetes any fancy device. If it is not user-friendly, he or she will not use it. So the development in technology through two directions: better accuracy and better quality of life. Dexcom G7, as you can see, when compared to G6, much smaller. Medtronic, they have Guardian Connect, now they have Simplera. much smaller. Freestyle, the other type of personal CGM, and I think you have here in Bahrain, came to know that you have Freestyle Libra 1, version number 1 here. As you know, it is flash glucose monitoring. You need to scan to see the blood sugar, or the interstitial sugar, exactly. There are other versions. There is Libra 2, which can give alarms to the patient on high or low glucose. And there is Libra 3, which we have now in my center. Okay, it is smaller and thinnest. This is the most accurate and the thinnest sensor in the world nowadays. As you can see, this Libra 3 versus Libra 1. This is the smallest and the most discrete sensor in the world nowadays. So as I said, this is what we need about technology and CGM. More accurate, more user-friendly, longer duration. Now, CGM, is it a tool or intervention? It is just for diagnosis and analysis of data, or is a treatment option? It is both. We use it for the patient side to analyze and predict his sugar, so he will take actions. And it is intervention also for the patient side to modify his behavior for food intake, for exercise, if he sees his sugar is going to be high. Also, it is intervention at the side of the physician to take decisions about management of diabetes. And we get this, what we call it, the ACG of diabetes. This is the AGB report, ambulatory glucose profile report from CGM devices. It gives the whole idea about the sugar levels and all metrics. We'll discuss it later in another lecture today, inshallah. Now, this question is true, or it has been shown that hypoglycemia risk dropped significantly with the first CGM. This is true or true? Okay, so all levels of hypoglycemia from first sensor, it has been shown it will be significantly dropped. Also, hyperglycemia will be improved. This meta-analysis showed also A1C changes, or in favor of CGM, also time in range in favor of CGM. These multiple studies about type 2 diabetes with the use of CGM showing from RCTs, real-world studies showing much improvement. Also, it's cost-effective, like relief study. A big study was more than 40,000 patients showing decreases in hospitalizations with DKA and hypoglycemias. Also, quality of life, it has been shown, it is in type 1, type 2 diabetes, better quality of life with CGM. And now this is the latest from ADA, like we need to give CGM to all patients with type 1 diabetes from first day. Okay? So it is from first day, give CGM to your patient with type 1 diabetes. This is evidence now from ADA 2024. Any patient on insulin, it is evidence A to give this patient CGM. Type 1, type 2 on insulin, even just basal insulin, give CGM. Others on tablets, we need more data. Of course, they can get benefit from some studies, but we need more data. But they can get benefit through modification of their lifestyle. Okay? Some studies from our center. We used the CGM in Ramadan to mitigate the risk of hypoglycemia, and it showed low risk of hypoglycemia, as you can see, just 3%. Okay, and good control, either those on sulfonylurea or basal insulin. Now, what about second part, a smart insulin pen or cap or button? It is then something smart or connected. You have here the smart pen, smart cap, will fix it, will put it over the pen, or smart button, you put over the pen like that. These devices or these connected pens, it records date, time, number of insulin doses. So when the patient injects insulin, it will be recorded and the amount of the insulin given. And this will be incorporated with CGM. What is the benefit of having this? It will overcome challenges we have with MDI therapy, like missing insulin doses or miscalculation of the dose, stacking of insulin, and the lack of reports. All of this will be solved, and it's improving to have now something called the MDI system. Now for the integration. We have insulin pump. I will talk about pump and integrated pump with CGM together. Regarding insulin pump, what is an insulin pump? Insulin pump is a device that gives the patient continuously a short-acting insulin. So the insulin inside it is a short-acting insulin. Okay, and it can be with tubes or tubeless. We call it patch pump. Okay, and it works like we want to make the pancreas. We want to give continuous insulin, the pink color here, like basal insulin, and boluses either with food or as correction like here, without food. Now this shape, you can see the same shape, but with different technologies. So you need to understand what is technology going on with that device. You can see the sensor and a pump giving insulin. But what is technology, we'll see. This is the integration. First level, we have sensor-augmented pump at 2 levels. Low glucose suspend, which will suspend the glucose level when the sugar coming down to the threshold of hypoglycemia. So the pump will suspend the insulin. Next level of technology is the predictive low glucose suspend. It will suspend the insulin before going to hypoglycemia. It will predict, okay? So instead of going down grade like this, no, it will stop insulin here, so it will continue without hypoglycemia. And now the most recent and the most advanced, which game changer in diabetes management, is the automated insulin delivery. We have hybrid closed loop systems and advanced hybrid closed loop systems. The new thing here, it is the same shape. The new thing, we have a controller or algorithm. Based on the glucose levels, the pump will give the insulin. As you can see, this is the sensor-augmented pump. The insulin is going at programmed rate, no change in relation to glucose levels. But with automation insulin delivery, the insulin will be up, down, even stops based on the glucose level to keep the glucose within range. So we move the variability from sugar to the insulin. And this is what normally we have in those without diabetes, the variability mainly in the insulin to keep the glucose stable. So this is the roadmap to artificial pancreas. As I mentioned, from just a simple pump to advanced hybrid system, what we have now, to reach to a completely closed loop and multi-hormonal closed loop in the future. So I want to show why we need automated insulin delivery. Okay, this is a study of one patient. To keep this patient with good A1C, he needs different insulin from day to day. Okay, so if I ask it, what is the main limiting factor in diabetes management? Is it the hypoglycemia? This is what we used to say. Because of hypoglycemia, this is limiting in my management. But we have learned that it is not the hypoglycemia, it is the variability in insulin requirements. It is the limiting factor, and this we can manage now with automated insulin delivery. This is like 50 years now of artificial pancreas road to get artificial like bionic pancreas. A lot of studies for automated insulin delivery, a long journey. These all landmark studies. Now just some systems to show you of the automated insulin delivery. The first one was the 670G, Minimid 670G. Okay, this is a pump getting the data and giving insulin based on it. This is a study from our center about the 10 days protocol for onboarding of patients from MDI to 670G. So we directly take patients from MDI to the most advanced technology at that time, and it showed significant reduction in A1C, significant improvement in time and range. Then the next one is the Minimed 780G with better control. And this is what we do in our clinic as a multidisciplinary team, doctors, educators, dietitians. We have 10 days protocol to onboard the patients. We check first the acceptance by the patient for the system. Then we give them the pump school education. Then we put the pump on manual mode for like 2-3 days. Then we move to the automation. This another system, Tandem Slim, with Control IQ. It is also with tubes. This another one, the Omnibot 5. Okay, and this is patch pump without tubes, as you can see. This is the CGM and the pump. This another one from Cambridge, the Cambridge Artificial Pancreas System. And it works with, can be with Libra 3 or Dexcom G6. And this is the only system approved in pregnancy. This is the latest one now, the Beta Bionic Islet. This pump it doesn't require carb count from the patient. Patient just will tell the pump before eating, I will eat usual meal or less than usual or more than usual without a need for carb count. So these are the many studies done for the current automated insulin delivery systems. As you can see, they achieved excellent time in range and very low time below range. Just I want to share with you one of the longest insulin pump study we have until date, the Comiseri study. This Comiseri study, they get 4 groups of patients, 2 groups using the usual finger sticks for monitoring, one on pump and one on MDI. The other 2 groups using CGM, either with pump or with MDI. So the main difference, we have 2 groups in finger sticks and 2 groups on CGM. And what makes the difference, as you can see, is the way of monitoring. Using just a pump or MDI without sensor, it doesn't matter, the same, but when you use CGM, it makes a difference, better A1C. This is at 1 year. At 3 years, similar results. 2 groups in finger sticks, 2 groups with CGM, they are similar and much better. Okay? And now we have data at 7 years. It is not published yet. It was presented in the last AACD in Hamburg. Okay, so at 5 years, it is the same. Then the group on CGM and the pump, they shifted from sensor-augmented pump to the automated insulin delivery. And here we can see significant drop in A1C with automated insulin delivery. So it makes a difference. This is a study from our center about Minimed 780G last Ramadan. We assessed patient satisfaction. As we said, we need good control and user-friendly. As you can see, this is scoring from 36. They are getting very high scores, better systems, better patient experience. From baseline, it is very high score. During Ramadan, during Shawwal, oral high scores with excellent satisfaction. And this is what NICE have now for automated insulin delivery, published recently, like 2 months ago. They will offer automated insulin delivery systems to all children, okay, to all who are pregnant or plan for pregnancy, to all adults with A1C more than 7.5 or disabling hypoglycemia. Okay, and why they will provide this? Because this removes the mental burden, improve quality of life, more effective and cost effective. Okay, so you pay for technology, okay, more money now, but you will save a lot by good control and avoiding complications. Same from EDA, recommending evidence-based automated insulin delivery systems. Now for the health apps. We have apps for glucose, insulin data, for carb count and nutrition, and for fitness. The main issues with the apps is that we need studies, rigorous studies, RCTs about them and safety. Okay, so maybe in the future, I will prescribe an app for my patient in the clinic, for example. And this is a study from our center about Druby app. It was a qualitative study about this app for control of diabetes in our patients. Now for doctor side. Technology supports telemedicine. How it supports telemedicine? Because technology, it is not just a device you give to the patient, it is an ecosystem. So this is the patient using whatever device. He can share the data with a caregiver, with the mother, with the spouse, okay? Data will go through the cloud to the healthcare, to the physician and the hospital, who can review reports and give feedback to the patients, whatever the patient, okay? And as you can see, this one of my patients, she opted to go for delivery in California, and she asked me to continue following her, and we kept following her, okay? And this, my communication with her obstetric team in US about her control. Excellent control, 82 time in range, excellent, no hypoglycemias, 2% only. She has excellent control and nothing to be changed in her settings. This also from our study in the last Ramadan, where about monitoring of the patients. As you can see, the patient wearing the system here, we give them a watch to follow their exercise. This study was about fasting in Ramadan and doing exercise. So it is like we get this first time to be done, such a study. We have data that this type of automated insulin delivery is safe in Ramadan. So let's go one step further. Let's make those patients with type 1 diabetes to fast and to do exercise also at night. And we'll see. As you can see, exercise can cause hypoglycemia up to 24 to 48 hours later. Okay? So through a wearable device, we can monitor the patient activity. All data are coming, and we can see in our computers such a graph about the patients with all of data about sugars, about their activity, heart rate, oxygen saturation. This is remote monitoring. I'm sitting in my hospital, patient at home. Now, the use of technology in some challenging situations. Type 1 diabetes with pregnancy, Ramadan fasting, exercise and fasting, old age, inpatient use. How technology can help all of this. CGM showed like the good results with pregnancy, and this from concept trial, where CGM becomes, after this concept trial, is the standard of care for any pregnant type 1 diabetes female. It showed better control in sugar and better neonatal and pregnancy outcomes. Again, the automated insulin delivery systems in pregnancy. These are the studies in pregnancy about automated insulin delivery. Some of them finished, like the AI adapt with Cambridge system, and some of them still going on or we released soon. This is IDAPT study. Again, automated insulin delivery showed good control throughout pregnancy and also pregnancy outcomes. Large for gestational age, reporting this study was the lowest reported large for gestational age in any cohort with type 1 diabetes, the smallest reported risk. And also in ICU admissions was the smallest reported risk for the neonates. And based on that, it is becoming a nice put automated insulin delivery as a standard of care for pregnant ladies. This publication from our center also about successful use of another system, 780G. It is off-label use, but because it is user-friendly, the females asking me, I want to be on this system. I don't want to change. I want to keep the automated insulin delivery. And I tell them, okay, we'll see. And this is like a publication from our two first cases, used Minimed 780G in our center. We published in this study about the techniques we used to make this system suitable during a pregnancy. What are the techniques you can review the paper, it gives a lot of concepts how to use this system during a pregnancy for better management. And this is one of them. She achieved all pregnancy, strict control throughout pregnancy, low risk of hypoglycemia, low risk of variability, with excellent outcomes at the end. What about Ramadan fasting? It is from Egypt, excellent control during Ramadan fasting. What about exercise? Excellent control during exercise. What about doing, as I said, our study, active fast study, we have done in Qatar, about fasting and exercise at the same time. It showed, this is still not published, okay? Time in range, significant, better improvement in Ramadan, time above range, better in Ramadan. What about use of old age? Usually how we can give old age technology? They are difficult for them. But evidence showed the opposite. CGM showed less hypoglycemia in elderly. Also, automated insulin delivery, the insulin pump and automated insulin delivery, better control, better time in range, less hypoglycemia. And this is a publication I published about one of my patients in the clinic. He has like almost 70-year-old with dementia. I just simplified his medication with igralexi and I gave him CGM, freestyle Libra. And you can see his A1C came from 11 down to 7. Time in range is 77 with zero hypoglycemia. So you can change the management and you can see what is going on with the patient. Also the inpatient use, especially with COVID, this emerging of technology. Now the cost effectiveness. So I need something to be effective, user-friendly, also to be cost-effective. I will pay a lot of money initially, but it will come back and save a lot. As you can see, this after 10 years of hitting the time range of 70%, you will save billions of dollars. Also, if you hit to 80%, you will save more millions of dollars. During a pregnancy, also it is cost-effective. You can see here you will pay more money for CGM, okay? You are not paying this money here with finger sticks. But you can see you will pay a lot for in-ICU admissions. So at the end, you pay here more, but you will save a lot of money, millions of money, because you just stopped more in-ICU admissions. But there are barriers to technologies that we need to overcome, barriers for development of technology. It is just like mobile phones, but with FDA approvals or authority approvals in our countries. So it is not just make iPhone 14, 15, and they just put in the market, okay? Also, affordability is an issue, But as I said, it is cost effective, and we need patient education and clinician education. If patient doesn't know what to do with the device, no benefit. If I don't know what I will do with the device to help the patient, no benefit also. Now the future. And the future of technology is endless. Just I will share some thoughts. Okay, this like the artificial intelligence can help with decision making on the doctor side and the patient side. Okay, this is very helpful. Like I see the patient 3-4 times in the year. Okay, in between the artificial intelligence and decision making systems can help the patient. So it is not a replacement to the doctor. Okay, our jobs will be saved, don't worry. Okay, but in between, this will help the patient. There is continuous ketone monitoring device. Okay, like this coming from Freestyle Libra. They plan to have a device with continuous glucose monitoring and continuous ketone monitoring also. Can we use CGM for diagnosis of diabetes, patients with pre-diabetes? This may be also used instead of using the A1C and the usual things, because we can detect the dysglycemia early with CGM. This is a study we are working on it in our center in Qatar with Qatar University and Wire Cornell University. This is something called the hypoglycemia sensor. So we try to get more sensors to detect the different inputs to help the management. Like this in form of glove here, but we plan to make it like a watch. It can like sensor for accelerometer for exercise, sensor for hypoglycemia, sensor for sugar levels in the sweat. So if we don't have a full closed loop, still the patient needs to tell the pump, I will eat. Okay? When we overcome this, this will be a fully closed loop. So what about giving the pump some data to reach to closed loop through other sensors? For example, this is an application in breast now, the study of it. It's Clue application. This application in the watch, Apple Watch, okay, from the gestures of eating, it can give data to the pump about the amount of food. Okay, so the pump will give insulin based on that. The patient doesn't need to hear the pump, I am going to eat. Just from the movement of his hand, it will try to count how many bites he's eating and give a dose. And it can even differ, it is a bite or just sips of water. Exercise, very challenging. We can use accelerometers and heart rate monitors also to give data about intensity of exercise to the pump. Also, we may think about digital twin algorithm. So just the pump will be with algorithm which is specific to the patient. No two algorithms will be similar. Even on our side, the teaching. If you heard about someone I'm not a physician, I'm not an engineer, I'm a physicianeer. So this one degree is started now in US. You will get dual degree, the MD plus MS in engineering. At the end, keep in mind, the center of management is still the patient himself or herself. Okay? Just giving your patient a device without engaging the patient will not change anything. You need to engage, with technology, engage two persons. Engage the patient, use it, and change the management by himself, and engage us, engage the doctors. Us as a doctors, we need to learn how we can modify management based on technology. If the patient coming to me in the clinic with a device and I don't know how to manage, how to read the report of this device, I will not make any change. And the patient also will drop the device, okay, although it is effective. So at the end, the take-home message, technology in diabetes management is becoming a standard of care, not an add-on. It supports the person and the healthcare team. It is a tool. CGM is a tool and intervention in the same way. Smart MDI decisions now available. Variability in insulin requirements, not hypoglycemia, is the main limitation for diabetes management. Automated insulin delivery systems becoming the standard of care. Technology helps people to manage different challenges. And technology is cost effective. There are barriers to overcome. Technology, a lot of technology is in the pipeline. And don't remember, engage your patient. Thank you.